Good afternoon, good morning, everybody. We have a lot of attendees at this webinar organized by Scleroderma Forum and funded by Arginex. My name is Francesco Del Galdo, and I'll be discussing today with my faculty, the role of autoantibody in systemic sclerosis. The Scleroderma Forum, for the ones of you that are the first time logging in, is an educational initiative where we are sharing the most up-to-date information on scleroderma research, and this information is kindly curated by a panel of experts in the field. You see here the faces of these international experts that are joining from Europe, US, and Asia. It's a global resource on development of scleroderma and systemic sclerosis and is under the guidance of the expert. There are sponsors that have this to happen. Of course, the sponsors have no say in the content of what we share. As I mentioned today, I'm joined by Professor Masataka Kuwana, Professor Christopher Denton, and Professor Yannick Allanore, and we'll be discussing about the role of autoantibodies. I will quickly introduce what is the role of antibody in accurate and timely detection of systemic sclerosis, and after that, we will have three brilliant talks. The first will be for Professor Masataka Kuwana on the discovery and significance of anti-RNA polymerase III antibodies. The second from Professor Chris Denton, autoantibodies in the classification and stratification of SSC. And the third is for Professor Allanore, targeting B cells and autoantibodies in SSC treatment. At the end of the three talks, there will be a question and answers. Please write up your questions, and then I will moderate at the end of each talk. As a disclosure, as I mentioned at the beginning, this very webinar is sponsored by our colleague friends at Arginex, but Arginex has no influence on the content of the presentation. You will see in the bottom of the webinar a window for question and answer. That is the place where you want to place your questions. And what are the learning objectives today? First of all, we'll discuss about accurate and timely detection of autoantibodies. What is the role in early diagnosis? Then we will learn how autoantibodies help the identification of different subgroups in systemic sclerosis and the implication for diagnosis and prognosis. And then of key autoantibodies for predicting organ involvement and optimized care across the multidisciplinary team, and then potential autoantibodies therapies in pipeline development. So this is our nice logo, and this is me again. So let me tell you, here it is. Let me tell you now what is the role of autoantibodies for early detection. Now, scleroderma is one of the few connective tissue diseases. Now, the hallmark biomarker of these diseases is the presence of antinuclear antibodies. And these have been discovered several decades ago. And in the beginning, it was only by immunofluorescence. And people were just observing that antibodies against nuclear antigen could have different patterns of fluorescence. And so the first classification of autoantibodies was made simply for how they look under the microscope. And you see here that with the serum of some patients, the pattern was speckled versus some others was homogeneous. There was a mixed pattern, could be a nuclear pattern, centromere pattern. Centromere is the center of each chromosome, and peripheral. With the refinement of the immunological techniques, we learned that these patterns were driven by specific antigens. And so we learned which were the antigens that were associated with the centromere. It was the EC centromere protein A and B, and with the speckle pattern, there are several, and so on. After that, there's been 20 years of literature that have deeply linked the presence of autoantibody with an activation on the immune system, and vice versa. So in the presence of a pro-inflammatory environment, there is a generation of autoantibodies, and more recently, the autoantibodies can sustain the production of type 1 interferon. Now, why this is so important? Because these autoantibodies are very specific for the different type of connective tissue diseases. And so it is extremely unlikely that a patient with anti-DNA topoisomerase 1 develops only symptoms that we classify as lupus, and so on. So at the beginning, there were very good biomarkers of clinical phenotypes, but then we learned that they're really marking a biology which is deeply linked with the clinical manifestations. And this is the exciting research of these latest years. Now, are they more than a biomarker? And this is what you will hear through this webinar today. Probably they're a bit more than a biomarker, and this is why some of the therapies are aiming directly at autoantibodies. Now, what is the role in scleroderma? Well, this is a review that actually I published with Professor Allanore now 6 years ago, where we try to put scleroderma in the context of a natural history of the different manifestations. And you see, while, let me see if I can point here. There you go, laser pointer. While we diagnose scleroderma here, when we detect either the first skin involvement or the first digital ulcers for some patients. And then scleroderma, of course, goes on, and this is just a review of the pulmonary arterial hypertension and ILD in the context of the natural history. We know that the autoimmune activity that sustains scleroderma is present before diagnosis. And so, and these autoantibodies are very good marker also the type of fibrotic and vascular damage. Specifically, for antitopoisomerase antibodies, different case series shows that they can be detected from 1 to 4 years. They were detected before the first sign of skin fibrosis. And whereas for anticentromer antibodies, the different case series range between 1 and 9 years before the diagnosis of scleroderma were made. So really, these autoantibodies are there since the very beginning, since even before we can detect clinical manifestation. And their presence or absence have a very important role. When this, one of the studies that was done with the Euster registry has really changed what we think of scleroderma and when does systemic sclerosis start. This is the very early diagnosis of systemic sclerosis study that was conceived by Professor Matucci and Professor Bellandolendone, where we collected through 42 Euster centers for 8 years patients that had been flagged as with very early diagnosis of systemic sclerosis, patients that had Raynaud's, and they had either capilloscopy changes, antinuclear antibodies, and puffy fingers. The study eventually collected enough patients for 5 years to determine how many went on and developed other symptoms of systemic sclerosis. And you see here, just to bring it to the autoantibodies, that the simple presence of autoantibodies was associated with 70% rate of progression to fulfill classification criteria versus only 31% of patients that did not have scleroderma-specific antibody at baseline. So even in the very early phases, the presence or absence of SSC-specific antibodies as a very strong predictive marker of future progression. And of course, the different VEDOS criteria could be analyzed in the context of the others. And here you see a simple dichotomous Kaplan-Meier curve where you see that the presence or absence of the scleroderma antibodies and puffy fingers, how does it change the risk of progression to fulfill classification criteria at 5 years. So even if we don't know exactly how and why, we know that the presence of this antibody is crucial for future progression. And you will hear through this webinar what have we learned from these antibodies, both for diagnosis, for stratification, and eventually what are we trying to learn from treatment. So with this, I'm very glad to introduce our first speaker, which is Professor Masataka Kuwana from University of Nippon Medical School in Tokyo. Please, Masa.
Thank you for the opportunity to speak. Today, I will feature history and journey of anti-RNA polymer III antibodies, from its discovery, assay development, and the clinical implications that have reshaped our management of systemic sclerosis. These are my disclosures. The clinical presentation in patients with systemic sclerosis, or SSC, is highly heterogeneous. But we now recognize that SSC patients can be divided into multiple independent subsets in association with SSC-related autoantibodies. Currently, at least 12 antibodies are well characterized. They are mutually exclusive and are strongly associated with distinct clinical phenotypes. More than 85% of the patients have one of those antibodies. When I was a resident, only 3 antibodies, anti-topo, centromere, and URNP antibodies, were recognized in clinical practice. And in nearly half of the cases, the specific autoantibodies were unidentified. When I was a resident, I saw 2 typical patients in this slide. These patients had a major impact on my research interest. Both patients had typical diffuse cutaneous SSC presented with rapidly progressive skin thickening and died of renal crisis. However, anti-topo, centromere, and URNP were all negative. The ANA pattern was somewhat different. One had speckle, the other speckle plus nuclear patterns. But this clinical observation motivated me to identify new SSC-associated autoantibodies. Using immunoprecipitation assays, sera from these 2 index cases precipitated multiple proteins with similar but not identical combinations. We finally identified autoantibodies recognize a multi-protein complex of RNA polymerase III in association with other RNA polymerases, based on ability to inhibit in vitro transcription mediated by individual RNA polymerases. Importantly, these autoantibodies are present in 5% of SSC patients in our cohort and absent in patients with other rheumatic diseases. Of note, 13 out of 14 patients had diffuse cutaneous SSC. When we compared clinical feature of anti-RNA polymer III positive patients with anti-topo positive patients in our cohort, there were striking differences. Anti-RNA polymer III patients were older at disease onset and presented with skin thickening rather than rayness. Most importantly, prevalence of renal crisis was dramatically higher, while severe ILD and beta ulcer were less common. Causes of death differed accordingly. Renal crisis predominated in the anti-RNA polymer III group, whereas ILD dominated in anti-topo positive patients. All studies conducted subsequently showed the higher prevalence of renal crisis in anti-RNA polymerase III positive patients compared with antibody-negative patient groups, although its prevalence varied from 7% to over 50%. Because of a clear clinical relevance of anti-RNA polymerase III antibodies to predict organ manifestations, I received many testing requests around the world, but the only available detection method was immunoprecipitation assay using radioisotopes, technically demanding, time-consuming, and unsuitable for routine clinical laboratories. So there was a strong global demand for testing of these antibodies, highlighting the need for a convenient, non-radioactive assay system. To achieve this goal, identification of the antigenic target within RNA polymerase III multiprotein complex is essential. For this purpose, we use immunoprecipitation assays using dissociated antigens and immunoblots using affinity purified RNA polymerase III antigens, and demonstrated that the major epitope recognized by SSC0 with these autoantibodies resides in the RPC155 subunit. Further epitope mapping found that the dominant epitope lies within the RPC155C region, covering enzymatic activity center. The minimal region of the major epitope on RPC155 spans more than 100 amino acid residues, indicating that high antigenicity requires preservation of the three-dimensional structure. This molecular characterization enabled the design of the reliable enzyme immunoassay. So we finally developed an enzyme immunoassay using the major antigenic fragment of RPC155 in a pilot study against immunoprecipitation as a gold standard. Sensitivity and specificity were both 100%, which is perfect. And a multi-center validation study involving more than 500 SSC0 sensitivity was approximately 91% and specificity was 99%. These results confirmed that the convenient immunoassay could replace the cumbersome immunoprecipitation assay in routine clinical practice. The assay system was patented in Japan, US, and Europe, and later approved as an in vitro diagnostic in over 50 countries. This transition from discovery to clinical implementation dramatically expanded global accessibility, enabling large-scale clinical researches and clinical use as a biomarker. One such example is the inclusion of anti-RNA polymerase III antibodies in the ACR-EULAR classification criteria due to their diagnostic importance. Our current knowledge about anti-RNA polymerase III antibody includes its association with rapidly progressive skin thickening, high risk for developing renal crisis and GAPE or watermelon stomach. There is also a well-established association with malignancy, particularly breast cancer, temporarily related to SSC onset. Survival in anti-RNA polymerase III positive patients has improved substantially by early detection of renal crisis through careful blood pressure monitoring. In fact, long-term prognosis may now be better than that of anti-topo positive patients, probably because renal crisis is more easily manageable than ILD. This slide summarizes the journey from clinical observation in 1989 when I was a resident to global implementation. It illustrates how careful bedside observations led to discovery, assay development, regulatory approval, and ultimately improved patient outcomes. I believe that this pathway exemplifies translational research driven by clinical need. There is a difference in the skin fibrosis trajectory depending on autoantibodies. In anti-RNA polymerase III positive patients, skin thickness peaks early and then regresses spontaneously, whereas anti-topo positive patients show more persistent fibrosis. In addition, recent transcriptomic studies revealed biological differences between these two diffuse cutaneous SSC subsets. These findings suggest that antibody-defined subsets represent biologically distinct phenotypes. A few years ago, I had the opportunity to write an editorial on a to-do list at diagnosis in SSC patients when anti-RNA polymerase III antibodies were detected. This includes recognition of early progressive skin disease, which is potential windows for disease-modifying therapy, monitoring of blood pressure closely for early detection of renal crisis, and screening for concomitant malignancy. So autoantibody status directly informs clinical decision-making in our daily clinical practice. So thank you for your attention. I'm happy to answer the questions.
Thank you, Masa. This was moving, to say the least. Finally see this story all panned out, and it's really, I think it's one of the most impactful pieces of research of the past 20, 30 years. Thank you so much for sharing it with us. And above all, the two steps, the discovery and then the dissemination. Now, well, yeah, I have to just collect my mind back. Thank you so much. Now, you have learned firsthand how these antibodies can mark such a different clinical outcome, right? And actually, you started from the clinical outcome to get to the antibody. Do you think that they're marking a specific biology? You quoted this last paper from Chris Denton group showing the different transcriptomes, but do you think that this antibody may effectively change cellular function, or they are marking a different type of damage? Because this is the question now, right? They're so specific. Are they actually contributing to a different disease, or they are marking a biology?
Yeah, this is a good question I want to answer, but current evidence shows that these antibodies are useful to mark specific clinical phenotype, but there is no sufficient evidence to show those autoantibodies are truly pathogenic.
I see.
Yeah.
So, for instance, you identified this by blocking the polymerase activity of the RNA pol 3. You realized that this sera was able to inhibit that RNA polymerization. Do you think this is happening in cells as well?
Yeah, actually, I previously tried to evaluate the ability of these autoantibodies to suppress actual enzymatic activity in the cells But when I added the autoantibodies in a cell culture, nothing happened.
I see.
But using the cellular lysates, these autoantibodies beautifully inhibit the transcription of RNAs mediated by RNA polymerases.
Oh, so you need to lyse the cells to see that, and just you can mark the enzymatic activity. Interesting. Okay. So now this was such a clear phenotype, and so that led you to this identification. Do you think there are other different phenotype, maybe not as evident as what we call today the RNA pol 3 phenotype? So today we call it the RNA pol 3, right? So do you think there are other antibodies out there that we cannot detect simply because we are not able to find such a different group of people, for instance, against gastrointestinal for gastrointestinal involvement, or for carcinosis? Yeah, this is group of people with carcinosis. Do you think there is a way of understanding whether there are more autoantibodies of what we know?
Yeah, actually, all the researches on autoantibodies were aimed to detect new autoantibodies related to certain clinical phenotypes. But we use the autoantibody library or cellular lysates on certain cell types. In that case, those assay systems could not find all kinds of autoantibodies in patients' serum. So I think there will be other clinically relevant or maybe pathogenic autoantibodies in a serum from SSC patients. So we still need more research on autoantibody discovery, and also the treatment of patients with B-cell depleting or autoantibody depleting therapies might work in the SSC patient. Now, many clinical trials are ongoing, but the data obtained from those clinical trials may provide the clue that the autoantibodies already identified or unidentified one can be pathogenic in the systemic sclerosis.
Yes, you're absolutely right. And this is a question I will do to, and I will ask to all the speakers, and you lead me beautifully to this question. So there is increasing evidence now that these B-cell depleting therapies have some clinical effect. And we started with rheumatoid arthritis, and we extended to vasculitis, and now all connective tissue diseases. And it's not a coincidence that these are all diseases in which we recognize an autoantibodies, right? In these seronegative diseases, we have a bit less of evidence. So do you think that this could be, and you already said, could be at least in part mediated by the antibody, but could be mediated by B-cell presentation of antigen to T cells? So that at the end, the antibodies that do not circulate, but they sit on the cell surface, may be fueling a T-cell specific response?
Yeah, I think it's a very interesting hypothesis. Probably the autoantibody itself produced in the circulation, but also present on the surface of B-cell plasma cells. So we need to think about the additional approaches to evaluate the pathogenicity of autoantibodies in the future.
Yeah, thank you so much. Last question, if you have the last 2 minutes. And how do you place the clinical value of IVIG and the role of autoantibodies in connective tissue diseases.
Yeah. The mechanisms of action of IVIG have been validated extensively in many autoimmune fields, and there are several different mechanisms. But one of the mechanisms is to bind the immunoglobulins to Fc gamma receptor and mediate some signal transduction on the Fc gamma receptor presenting cells, also bind to also compete with the action of autoantibodies by binding the Fc gamma receptors. So I think that if the IVIG is effective in some conditions, this might indicate the role of autoantibodies in the pathogenic process on such conditions.
Yeah, there could be two faces of the same coin. I entirely agree. Well, thank you so much, Masa. First of all, for what you have done to the field, and then for summarizing it in this webinar. Thanks again.
Thank you.
Well, thank you. We are back. You might have noticed that was a recorded session. Unfortunately, we tried to get Masa to stay up until 1 a.m., but he's still a very busy clinician and he preferred to record. Nevertheless, if you have questions, me and the other panelists will try to address them. This is always such an interesting story. Now, we go ahead and we move to next talk. Yasin has already been announced but not preempted, and is autoantibodies in the classification of and stratification of systemic sclerosis from Chris Denton at Royal Free Hospital and UCL Medical School in London. Chris, the floor is yours.
Thank you, Francesco. I'd like to thank the organizers for the opportunity to speak. It's a real honor to be speaking after Professor Kuwana, who was really so instrumental in the field. So here are my disclosures for the relevant to my talk. Thank you. So I'm going to talk about autoantibodies in classification and diagnosis, really building upon the fantastic story we heard around RNA polymerase, how we're using the autoantibodies to understand perhaps the basis for molecular and cellular heterogeneity that we've heard about for polymerase antibodies, and just finally consider how antibodies might also be very relevant when we're thinking about limited cutaneous systemic sclerosis. So I thank you. So as we heard, systemic sclerosis is a heterogeneous disease, and traditionally, before we focused on autoantibodies, we really classified our patients according to the extent of skin involvement. In our large cohort at the Royal Free, we know that around 1/3 of patients have diffuse cutaneous skin disease, and about 2/3, the majority in fact, have less extensive skin involvement, affecting the extremities, face and the neck. They have limited cutaneous disease. However, we also know that whatever skin subset you're in, you can develop any of the organ-based complications. And this is important because it leads us to start to be able to predict when a patient presents to us in the clinic, what they are most likely to develop in terms of complications as the disease progresses. And if we focus on the life-threatening complications, here you can see in a cohort from our own series published just over a decade ago now, nearly 700 patients where we carefully followed them through the course of their disease. We think this reflects the incident frequency of major complications. And what you can see is if you have diffuse skin disease, around half of the patients will ultimately develop significant lung fibrosis. Conversely, limited cutaneous patients, about 1 in 4 develop significant lung fibrosis. So clearly having more severe skin fibrosis to some extent predicts a greater risk of lung fibrosis. But for other complications, such as pulmonary hypertension, shown in the red line here, there's that same time-dependent risk in both subsets. So skin subsets clearly are not the only way that we can stratify our patients. And building upon the exciting work that Professor Kuwana presented, we have always been interested in using the autoantibodies that we use for diagnosis in systemic sclerosis to try and predict at an early stage what the clinical course might be for an individual patient. So here we are in a larger number of patients, more than 1,300 patients, followed for a long period of time with careful clinical annotation. And what you can see in the top panel is the difference in survival for the different autoantibody profiles. Anti-centromere antibodies, shown in blue, having a very good long-term survival. In fact, that group of patients who are ANA positive but have no characterized extractable nuclear antigen or antibody target, having the worst survival. So clearly antibodies do make a difference. And they're of course present at diagnosis, and so they're present throughout the course of the condition. We've already heard just how strong the association is between anti-RNA polymerase 3 and the development of scleroderma renal crisis, and that's shown by the red line here, with a 10-fold increased risk in our cohort of having a renal crisis if you have that antibody. But we also see clear associations with the lung complications. And if we look at the smooth hazard ratios shown here, you can see just how high the risk is of developing early significant lung fibrosis if you have the anti-SCL70 or topoisomerase 1 antibody. And this crosses both skin subsets. So whether you have limited or diffuse skin disease, you have that same high risk if you have the anti-topoisomerase antibody. Conversely, for pulmonary hypertension, there's a high risk of developing early PAH if you have an antifibrillin or U3-RNP antibody. And you can see other antibodies such as centromere and polymerase linking to pulmonary hypertension later in the disease. So Professor Kuwana introduced the concept that these diagnostic antibodies are largely mutually exclusive, and that is the case. And that was a puzzle in the early days, but now I think we understand that because in fact, each of these hallmark antibodies has a very specific MHC class II haplotype association. And what that means, and this was introduced by Francesco at the beginning of the talk, is that in that inflammatory microenvironment where these autoantigens are available and presented, only if you have the particular MHC haplotype that allows you to generate a specific autoantibody do you develop that antibody. So in a way, you might say that the systemic sclerosis phenotype and the autoantibody is to some extent predetermined genomically in our patients. But this certainly explains why you generally only have one of these hallmark antibodies in clinical practice. So in our analysis, we used the combination of skin and autoantibody profile to come up with an outcome-based classification for our patients, and it's summarized in this heat map. And you can, of course, see those associations with anti-RNA polymerase and renal crisis and anti-topoisomerase and pulmonary fibrosis, with increased risk showing as red and reduced risk being shown as green. But if we, for example, consider cardiac systemic sclerosis, so a really challenging complication, some interesting associations arise here because you can see again antifibrillin or U3-RNP antibody strongly associated with a high risk of cardiac involvement in the first part of the disease, whereas anti-SCL70 being associated with cardiac involvement in later stage disease, but only really a high risk in diffuse cutaneous patients. So by combining antibody and skin subset, we can make practical selections and risks about the patients as we follow them up in the clinic. But what's interesting is that these associations don't just associate with clinical outcome, but they start to also impact on treatment response. And I'll just show you one example of that. And this comes from the post-hoc analysis that we undertook of a large phase 3 diffuse scleroderma trial. So this was the Resolve 1 trial, recruiting nearly 400 patients with diffuse cutaneous systemic sclerosis, many of them with early stage disease. It was a trial to test the efficacy of linabacim. This was a synthetic cannabinoid receptor 2 agonist, and it was hoped that this would be a helpful treatment in improving outcomes in diffuse cutaneous systemic sclerosis. Unfortunately, when the trial was analyzed, there was no benefit for the two arms taking active linabacim compared to placebo. But it turned out that the reason for this is that this was a very pragmatic study that allowed patients to be on background immunosuppression, including mycophenolate mofetil, methotrexate and other immunosuppressive drugs. And the true answer from the interpretation of this study is that using the composite response index or responder index, where a value of above 0.6 means the patient has significantly improved over 12 months, that the background treatment in all treatment arms was able to take the patients over that threshold, and you can see that they all achieved a CRIS response of at least 0.8. But what we were able to do then was go back and look in detail at the background immunosuppression that was used in these patients, which wasn't pre-specified, and so covered the range of drugs that are in routine use. You can see here that the largest number of patients were on MMF, but a significant number also on methotrexate, and importantly, a group of patients were on no immunosuppression whatsoever. And so we were able to go back and with carefully pre-specified endpoints, explore the impact and factors that determined responsiveness to the background immunosuppression. So relevant to today's talk, I've just shown here the panels that show how patients did differently if they were on mycophenolate mofetil compared to no immunosuppression by autoantibody profile. So what you can see is that being on MMF, the solid black line, gives you a big advantage in terms of decline in lung function, shown in the bottom panel on the left, and also is associated with a much greater improvement in MRSS over 12 months. So this really supports the routine use of MMF in early diffuse systemic sclerosis. Interestingly, the ATA-ARA negative group of patients also show that same benefit, but the anti-RNA polymerase patients are a little bit different. These patients are less at risk of early lung fibrosis, and you can see that immunosuppression doesn't really impact on the serial lung function. But what's interesting when you look at the skin is that there's really no impact in the first 6 months of follow-up, but from then there's a separation where MMF does seem to make a difference. And this really aligns with the observation that there is a spontaneous improvement in skin score, often in early stage anti-RNA polymerase positive patients. So we see that difference in response even more when we analyze other clinical trials, and I'll just summarize that in this table. So there's been a very busy and productive space, the clinical trials over the last decade in systemic sclerosis, and we've had some successes. In Japan, the DESIRES trial led to approval of rituximab as a treatment for systemic sclerosis, treating skin and lung disease. The phase 2 and phase 3 trials of tocilizumab showed significant benefit for systemic sclerosis-associated interstitial lung disease and led to FDA approval for this indication. And there's global approval for nintedanib as treatment for systemic sclerosis-associated ILD from the Census trial, testing nearly 600 patients with SSc-ILD with the use of nintedanib, an antifibrotic. But interestingly, the responses to immunosuppression or to the target treatment differ between the autoantibody subgroups. For example, the response to tocilizumab in the FASCINATE and FOCUS trials was much more in those patients who had anti-SCL70 or anti-topoisomerase 1 antibodies. And interestingly, in the Census trial, those that were ATA negative actually had a numerically greater treatment response. More importantly, some of the trials that didn't achieve their endpoints, so they were negative clinical studies overall, when you look at the subgroup by antibody, you did start to see significant treatment effects. For example, for abatacept in the ASSET trial and for riociguat in the RISE-SSC trial, the anti-RNA polymerase subgroup showed a statistically significant and clinically meaningful impact on MRSS, which was the primary endpoint of the study, even though overall there wasn't a positive treatment effect. Just to show just how different the results are for some antibody groups, I'll go back to the tocilizumab phase 3 trial, the FOCUS trial, and here you can see the overall trial results looking at the change in FVC over the 48 weeks of the trial. So here you can see that if you were randomized to placebo, you lost a significant amount of lung function of FVC over the 48 weeks. But if you were randomized to tocilizumab, there was an improvement back by 16 weeks to baseline, which really then remained entirely stable throughout the study. if you look at the 2/3 of patients that actually had interstitial lung fibrosis on their baseline CT scan, the impact is even more. And in fact, this is what's driving that treatment effect. And you can see here that the difference between being on tocilizumab or on placebo is 240 mils at 48 weeks. So a really clinically meaningful impact. Of course, these patients were on no background immunosuppression. This was a true placebo-controlled trial. But what was interesting when we went on to do a further analysis is that you can see here that the treatment effect is really driven almost entirely by those patients that are anti-SCL70 or topoisomerase 1 positive, with the ATA negative group just showing a trend of benefit. So putting all of this together, it really becomes very compelling to try and understand what are the biochemical, biological differences between those autoantibody subgroups that might be differentiating the natural history and also the treatment response to those therapies, particularly those targeted biological therapies. And this is what underpinned the biopsy project. So this was an academic collaboration between University College London and the GSK R&D department. And what we did was that we wanted to look at early diffuse cutaneous systemic sclerosis, but we wanted to look at those patients in the context of later stage disease, limited scleroderma, and of course, healthy controls. So we recruited a total of 68 patients, and the goal was to really focus on the 21 patients with early diffuse cutaneous systemic sclerosis, where we had these important control groups to help us interpret our analysis and our data. So this was the overall trajectory for skin score for those 21 patients with early diffuse cutaneous systemic sclerosis. This was an incident cohort, so you can see as the patients came into the clinic for the first 3 months, there was continued worsening at a group level. And then these patients were all started on treatment, typically on mycophenolate mofetil, and then other drugs were added as needed. And there was an improvement over 12 months, as you can see. But in a panel that I'm really honored that Professor Kuwana included in his talk, we looked at the skin trajectories by autoantibody, and you can see, as we might have expected, that improvement in the anti-RNA polymerase that start off with a much higher skin score compared to the other two groups. So this was very encouraging and led us to think that we might be able to define molecular differences. And we went on to do blood and skin biopsy proteomic and transcriptomic analysis, initially using bulk RNA sequencing. And I've just summarized some of the data here. The data are all published now. So here's the PCA plot for the bulk RNA sequencing, and just showing that you can differentiate the blue circle, which is healthy control, from limited cutaneous disease, from established diffuse disease, and then the most extreme gene profile being in those with early stage disease. But if you let the data sort themselves with unsupervised clustering in this heat map, you can see quite how clearly these data sets organize themselves according to that clinical phenotype, with the early diffuse cutaneous patients all clustering at one end of the spectrum and the healthy controls at the other, with the established and limited patients somewhere in between. So this really supported our hypothesis that you could link the clinical phenotype in these patients to the gene expression phenotype. But we then wanted to ask the specific question, could we define gene expression differences between those two autoantibody subgroups of early diffuse cutaneous systemic sclerosis? Very encouraging, a 61 gene signature was completely successful at separating these two groups. And so we were then able to go back and do genome-wide pathway mapping in the skin biopsy samples. And here you can see, using the bulk RNA sequencing data, a summary of the outcomes. And what this tells us is there are overlapping or hallmark pathways that are always activated in early diffuse cutaneous systemic sclerosis: interferon pathways, the IL-6 JAK-STAT pathway, TGF-beta signaling. But very interestingly, and perhaps relevant to those differences in outcome and treatment response, there were some pathways that were only significantly upregulated in the SCL70 positive patients, Wnt and Notch signaling, and PI3 kinase AKT pathways were only significantly upregulated in the early ARA positive patients. So we went on in an extended study in a second cohort of patients to try and understand the cellular basis of this diversity. And here you can see the UMAP plots for a series of samples taken from early and late stage diffuse cutaneous systemic sclerosis, and again comparing with healthy control. And you can see the differences in the keratinocyte cluster, the differences in the fibroblast cluster. And when you do a pseudo bulk analysis here, you can see at a group level that these single cell data again clearly differentiate the healthy control in blue from the early diffuse shown in red and the later stage diffuse in green with more extreme gene expression. But in fact, if you then subgroup the patients by antibody, you can see a much clearer pattern that again reflects that natural history that we see in our treated scleroderma patients. So here, and I'll just take you through in a little bit more detail, you can see the healthy control on the right, and you can see that in the early stages, the RNA polymerase patients shown in red are the most extreme. These patients over time, as the disease progresses, move here, and so they actually move much more back towards a normal gene expression profile, consistent with that spontaneous improvement that we see in the clinic. But interestingly, the anti-topoisomerase patients that start off with a less abnormal RNA sequencing profile, at the later stage disease, these are really driving that difference. And of course, that's important because we know that the anti-topo patients have a much worse long-term outcome, including, of course, predilection to lung fibrosis. So we went to do pathway mapping from our single-cell data sets. And again, we were able to show that there were pathways that were common to all early stage patients, whether they're RNA or topoisomerase antibody positive. But again, we confirmed that PI3-AKT signaling pathway activity was really exclusively seen in the RNA polymerase positive patients. So we know that in diffuse cutaneous systemic sclerosis, the antibodies are very useful. What about limited disease? So limited disease is important because it's the majority phenotype. And of course, it has one hallmark antibody, and that's the antisentinel antibody. But as I showed you in that overall survival, antisentinel antibody is in fact associated with quite a good long-term outcome. So this was important. And in the recently published minimized clinical trial, we hypothesized that routine use of immunosuppression may be helpful, but may be particularly helpful in limited patients that are antisentinel antibody negative. So the minimized trial that we've published was a pilot feasibility study, not designed to test this endpoint, but just to test the feasibility of this trial design of stratifying patients in this way. And in the study design, we designed a novel composite endpoint of time to clinical worsening, the minimized endpoint, and the endpoints are summarized here. So essentially it was time to scleroderma worsening that we feel was particularly important for limited cutaneous patients that are followed up over a long period of time. We then went on to validate this minimized endpoint, and in fact has now been validated in two cohorts, the STRIKE cohort from Professor Del Galdo in Leeds, and here you can see in the SMART cohort, the Royal Free cohort in London, and these data were just presented at the World Congress in Athens. And what it shows is that certainly you do see progression of limited disease over time in around 40% of patients, so it's a really meaningful disease over a long period of time. But you can see those patients, the blue line with antisentinel antibody, have a significantly lower risk of progression. So stratification in limited disease is also likely to be very important. So all of this has been incorporated into the current recommendations for management, and here the BSR guidelines just highlight that in the classification section of this figure, that the antibody and skin-based subset is very important in planning management. And of course, the anti-RNA polymerase patients are very important in highlighting the need for cancer screening. So what I've shown you today, I think, is that autoantibodies are really central not only to diagnosis, but also classification, but they also provide a route to really try and understand better the biology of the disease. And hopefully we will unravel that in future research to better understand the pathobiology of the disease. So thank you very much for your attention.
Chris, there we are. First of all, thank you so much. Thank you so much for your brilliant talk. There is a question from the audience, which is actually very interesting. Do you think it makes sense to repeat anti-RNA polymerase III antibody once these have been negative ones? Or have you ever seen them changing?
Yeah, so it's a great question, and it's an important one. So in fact, in our practice, we do have generally a policy of repeating this scleroderma antibody profile every 12 to 18 months in our patients during follow-up. And although it is infrequent, we do occasionally see the development of another autoantibody, very occasionally we've seen development of a new RNA polymerase III antibody and a change in phenotype to that typical pattern of disease. I think most often we see mixed antibodies associated with anti-U1RNP antibodies. But I think it is worth repeating serology from time to time, but certainly not at every visit. And certainly, of course, if there's any clinical change. But I must say that it's very infrequent to see a patient moving from negative to positive for an antibody such as polymerase III, but it can occasionally occur.
Yeah, it's also my experience. Now, I was very interested from the data you showed that suggests that there is clearly a genetic drive into the type of autoantibodies. And when I think on the source of this antibody, these are ubiquitous antigens, of course. They are present in every single nuclei. But do you think that they can come from different cells? What is the original source of the antigen that eventually has triggered this antibody? I know you don't have data, but so this is an opinion, yeah?
So I think that's a fascinating question. I suppose, my bias, and it is just a bias or a hypothesis, is that the early events in systemic sclerosis almost certainly arise around tissue damage, and that might be at an epithelial surface in the skin, in the lung, or even perhaps in the gut. So I think this epithelial damage is very likely to be a source for that early stage, perhaps exposure of the antigens. My feeling is that once the antigen, it's most likely that the autoantigens are present in a more ubiquitous way than the autoantibodies suggest. And I think that's really where the immunogenomics comes in, because I think that it may be that the nature of the tissue damage in systemic sclerosis in early stage, or even in Raynaud's patients that are sort of pre-scleroderma, is allowing the antigen to be presented, and then the immune system can take over from there. But of course, as you said, the consequences of that antibody-antigen interaction are fascinating, particularly thinking about whether that leads to the sort of pathogenic events. So I haven't answered your question, but I think tissue damage really is probably the root for the antigen, and then the immune system probably takes things from there.
Yeah, because after I read all the papers in the myositis field, looking at the autoantigens that eventually are the target of these antibodies expressed in the muscle, of course, I have to question where is the original antigen in scleroderma. But yeah, more work to do there. And we have only 1 minute to go. There is one more question. Clearly, trying to tap into your experience, and the question is, have you used or what is the benefit, in your opinion, of combining methotrexate and mycophenolate, or rituximab and mycophenolate, especially for skin joints and ILD?
So to a very brief answer to say that in clinical practice, and this is where our practice always goes beyond what the recommendations and guidelines suggest, we certainly use combination immunosuppression. And in my experience, combining a targeted biologic with mycophenolate has been very helpful in some patients. So that might be rituximab or indeed tocilizumab, for example. We do, in a small number of patients, combine methotrexate and mycophenolate, particularly those patients with overlap disease with prominent arthritis. And certainly we sometimes see benefit using that combination that we don't see with either single agent in individual patients. But again, that's moving into expert opinion away from formal recommendations.
Yeah. Well, thank you, Chris. There are a couple more questions, and we'll see whether we can answer it at the end. There are certain type answers too, and very interesting about fibrosis in Japan and antibody profiles in Jedi's mobility. And now it looks like we are ready. Can we please go in presentation mode again? Very good. For our next speaker, Professor Allanore from Université Paris Cité in an Hospital Cochin in Paris. Yannick, the floor is yours, targeting B cells and autoantibodies in SSC treatment. Please put Yannick on, and we are ready. There you are.
Thank you, Francesco, and thank you for the organizer for inviting me to take part in this nice session about a critical aspect for systemic sclerosis. So here are my disclosures. So now we are going to move to the treatment part. And as an introduction, I would like briefly to remind you which are the key players we are talking about when we speak about autoantibodies, the cell to produce the autoantibodies, where they come from and how they mature. On this very simple cartoon, I just wanted to highlight the biology of the B cells, because as you perfectly know, these cells are going at the end to produce the antibodies and autoantibodies that we are talking about. Just to remind you that there is a nice population that you can see on the left that can be important for immunoregulation. We do not know much about this in systemic sclerosis, but maybe it will come later on because it is actually part of the, let's say, the game to try to target precisely the B cells in this context of autoimmunity. But of course, important cells are the mature and premature cells that we are commonly targeting in our practice. These cells express CD20, CD19, that we will see are now common targets using different strategies. These cells, when they become mature, do have some biological effects related and not related to the autoantibodies, and this is important. Here you have the antibody-independent functions, presenting cells, production of cytokines, and then at the very differentiated stage, you have the antibody-dependent functions that they are related to the plasma cells. And you know that the plasma cells have a specific marker, which is called BCMA, which is not expressed by the other mature B cells. That we will talk later on about the first strategy used in systemic sclerosis to target specifically this cell subset. We have been lucky in the recent years, and I think we are going to continue to be lucky in the next years because really the field is expanding quickly with more and more drugs available in this field. Again, to try to be more and more precise to target these cells according to what is expected about the pathogenesis, the specific roles of the different subsets of cells, and these autoantibodies. So here you can see all the cell surface marker or cell specificities that have been targeted with different type of drugs. I put in blue the one for which we have already some data in systemic sclerosis that I will develop in the next minutes, and in dark black, the one for which data are about to come. As you can see, BAF is a critical marker of the B cells, which is actually under investigation with two different compounds. Some of that to come. We have also some let's say, more sophisticated compounds, like some B-specific that can target more than a single molecule, like here BAF and IL-17. And then if we go even deeper in the sophistication of the molecules, we have T-cell engagers, and I will talk more in details in the next bit, and of course the CAR T cells, for which we have the first experiences in systemic sclerosis. So let's start with the drug that we are using today in our practice. And as Professor Denton was saying, this drug is part of the different set of recommendations that have been published. There are some observational data that were very stimulating, particularly coming from USTAR and some other groups. And the critical study to support the use of rituximab came from Japan. It's not a very large study, 54 patients with a phenotype of diffuse cutaneous subset, not very severe regarding skin, 14, 16 of MRSS at baseline. The majority of the patients are ALD, and rituximab was mostly used as a single therapy, not in combination, but the patient could have been receiving previously some synthetic immunosuppressants. And why this study is absolutely instrumental. It is because after 6 months of follow-up, you can see here on the upper part the trajectory of the MRSS with a progression in the placebo arm and a disinfiltration in the rituximab group, which is significant. As you can see, the delta, the difference between the two arms after 6 months is quite large, 8 units of MRSS, which is statistically significant. And what is further stimulating in this study is that in parallel to the skin, you can see that FVC after 6 months can be considered as stable for the patient receiving rituximab, while the patients that were receiving the placebo had a decline of FVC, not very large, but it was statistically significant, which here the bar of the p-value p0.005. And so for the first time in the single study, not very large, not very powered, the phenotype of the patient is not absolutely well established, but in the single study at the same time, skin and lung were improved by an anti-CD20 study, so targeting premature and mature B cells. Few years later, as you can see, there is another study which is further supporting the effect of rituximab. Here it's not specifically or only systemic sclerosis, it was interstitial lung disease in the subset of non-specific interstitial pneumonia. And the study is particularly interesting because it was the comparison of upfront combination therapy. So we go back to the comment about combination therapy. It was rituximab plus MMF versus MMF alone. Again, not very large. Nevertheless, you can see here the two groups. So almost 80 patients, including 23 with systemic sclerosis. All of them have NSIP. And it's very interesting to see that if you combine MMF and rituximab, you see a gain in FVC for this patient, while the patient receiving MMF and placebo have a slight decline. And this is reaching a difference, which is not very large, but it's short-term follow-up. And the delta is close to 3.5, not very far from the MCID defined in systemic sclerosis. So it is stimulating and it is further adding to the benefit that may be provided by rituximab. There is an ongoing follow-up study specifically done in systemic sclerosis. So this data support the benefit that can be provided by rituximab. Then we enter the field of T-cell engagers because we have now very recent data, very stimulated. You know, these data are obtained thanks to the collaboration we may have with the hematological group because they are using these drugs in different hematological conditions. And you know that this BCMA bispecific can link the CD3 positive cells to the BCMA positive cells, so the plasma cells, and induce a cytolysis of these cells, so deplete these cells, particularly in the tissue, and so it can be very interesting to observe the outcome. So we do not have by now randomized controlled trials, but we have a first experience, a first case series, 5 patients, all with diffuse, large range of disease duration. All of them have NSIP. MRSS is quite high baseline, and it's interesting to note that all of them have some marker of cardiac involvement, meaning a severe phenotype, and all of them failed after more than 3D months. In a case series, it's difficult to draw conclusions regarding efficacy, so this is the reason why I start with safety. And as you can see, the safety is interesting to take into account because the majority of the patients, 3 out of the 5, did develop CRS, so cytokine release, that required the use of tocilizumab. So it means that the use of teclistamab induced a quite significant cytokine release syndrome. And you can see that this has been also observed after the initial delivery of the drug. It's interesting to note that no ICANS, though neurological disorders, were observed. Regarding the infection related to the change in the hematological cells, you can see that it was observed some effects, some adverse events, related to respiratory infection. One patient had 2 episodes of pneumonia and some esophageal candidiasis. So you can estimate the safety. It's clearly a drug that has to be carefully followed after the administration with in close collaboration with the hematologist regarding the side effects that may be observed. For effectiveness, in a case study, this is what we can, I think, observe. MRSS went down for a large majority of the patient. The inflammatory and poor prognosis factors, tendon friction rupts disappeared in all the patient, and USTAR activity index was also reduced. Regarding lung, you can see on these pictures, the changes were quite mild, and it was not really striking to see the reduction of ILD in the patient treated with teclistamab. Some other data regarding the experience of this group. As you can see, the depletion in the immunoglobulins has been really significant and required the use of IVIG for the large majority of the patients. And in addition, this group, according to their experience in hematology, decided to use as a maintenance therapy rituximab after the use of teclistamab. So we can see that it's quite an aggressive regimen with BCMA bispecific followed by rituximab maintenance with the requirement of tocilizumab in free case and IVIG. In parallel, what you can see, and maybe we will talk about this at the time of the question, you can see the effects on the autoantibodies, which are quite striking and that have not been observed so far with some other drugs, with a really significant and major reduction in the anti-topoisomerase antibodies. Our group, together with the group of Strasbourg, we reported at the last World Congress and published in Annals of Rheumatic Disease these last days, the experience with another T-cell engager, which is blinatumomab. And here we are not targeting the BCMA positive cells, but the CD19 positive cells, which means mostly mature B cells. So like in the previous experience, case series with, of course, inherent limitations, but quite early patient, topo positive, inflammatory activity, failure of at least 3 demands. Conditioning regimen, we used the regimen for blinatumomab that is used classically in hematology with 9 micrograms per day for 7 days, followed by 28 micrograms a day, continuous IV for additional 7 days. We stopped for this patient a classical immunosuppressant. Maybe we can discuss about this later. And because of the design of the study, we are reporting here safety, immunological changes, and scleroderma manifestation. Regarding the safety, it was really very good. The tolerance was excellent. 2 very mild CRS, needing not any aggressive treatment, no need for tocilizumab in this patient. Regarding the immunological effect, you can see that there is really a significant drop of the circulating CD19 positive cells, followed by a quite fast and quick repopulation in the circulating B cells. Regarding the other immunological effects, you can see here the immunoblot for the anti-topoisomerase antibodies. Here you can see the measurement of these autoantibodies using ELISA assay. And as you can see, and it's really different from what has been reported with the BCMA bispecific, T-cell engagers, sorry, we observed no decrease, no change in the anti-topoisomerase antibodies. And regarding the clinical effects, I have to say that we try to record MRSS, of course. We observed a drop initially, but a reascension, an increase in several of the patients that we have been treating. 3 out of the 5 patients had pulmonary arterial hypertension. It is also one of the characteristics of the study, and you can see that they were progressing and they were stabilized after the use of blinatumomab, but we cannot say that we have improved the pulmonary pressure. Regarding patient-reported outcome, fatigue, global assessment, pain Raynaud's, you can see a trend, an initial trend of benefit, which is of course difficult to interpret because it's just an observational study. But after few weeks, you can see that we had to restart some more specific treatment like tocilizumab or MMF in 3 out of the 5 patients. So the clinical effects were modest and usually transient with blinatumomab with the regimen we have been using, which may be a matter of discussion, and in a series of patients that were particularly advanced and severe. Then I move to another strategy, which is of course really actually fascinating, which is the use of CAR T cells. And I will show you 2 studies that are using CAR T cell directing toward CD19. Both of these studies were presented at the last World Scleroderma Congress, and I thank Professor Kana for sharing the slides. First is the BMS drug, and this study is particularly interesting because it's a basket trial, and for scleroderma, you can see that the patient might have a diffuse subset, MRSS higher than 10, and some progressive ILD and the failure of at least one synthetic immunosuppressant. Regarding the series that have been reported, it becomes now quite a large group because 31 patients have been treated. Again, mostly diffuse, 50% with ILD, baseline MRSS 31 as a mean, patient global 7, and the failure as a median of 3 previous drugs. I start with safety because it's of course critical for us and for the patients. You can see that CRS was observed in 61% of the patient, but the reassuring point is that it was mainly grade 1 and it required the use of tocilizumab in 40%, approximately 40% of the patient. ICANS were also observed, and for a few patients, you can see that the grade was quite high. So it has to be taken into account because ICANS, neurological manifestation, can be seen after the use of CAR T CD19 cells, and it required the use of steroids. So this is for the safety. Regarding the efficacy, still it is an observational study with the inherent limitation. Nevertheless, you can see a trend of improvement with globally a reduction in the MRSS, which was quite high at the beginning of the study. But I would like to highlight 2 other aspects of the efficacy analysis. The first one on the left is the changes of RNA pol-free autoantibodies, because this population of patients was common, in fact, in this study because of the recruitment in the US and Canada, and also in the UK, where RNA pools are probably more common than in some other areas. And you can see the very striking trend of decrease in RNA pool-free autoantibodies. And the other results that for me is particularly striking is the fact that after the last follow-up of these patients, you can see that 30 out of 31 remain off therapy after a single infusion of CAR T cell. And this result, I think, is particularly striking. And even if additional data and longer follow-up is required, it is particularly stimulating. The other study is investigating another CAR T cell, also targeting CD19 positive in refractory patient. It's the preliminary results that were reported in 6 patients. This is a trial supported by Novartis. You can recognize the skin involvement quite significant. FVC was not very low in this group of patients. You can see the distribution of the autoantibodies and the previous use of treatment. It's slightly different from the previous compound, but of course, the number of patients is smaller. You can see CRS of low grade and no ICANS reported with this compound. The results in the 6 patients, you can see a trend of decrease of MRSS observed in all the patients, and you can see the repopulation of the CD19 positive cells that have been reported. So these studies are ongoing. Usually they are moving now to randomized controlled trials with the difficulty to build trial design with a real comparison with CAR T cells. Nevertheless, this is what we need to better evaluate the risk-benefit ratio of this drug in the future for our patients. And I would like to end by citing another strategy. We have seen which cells we can block, which cells we can deplete. And because we have been today talking a lot about the autoantibodies, there is a new strategy that appeared recently, which is interfering with the recycling of the immunoglobulins, including the autoantibodies. And this is the property that relates to the FcRn. In this complex cartoon that I encourage you to see more in details, you can see what is the biology of the recycling of the autoantibodies, of the antibodies and autoantibodies, and how we can interfere with this by interfering with the FcRn to modify the recycling and then the ability of the autoantibodies to continue to drive some biological effects. And I would like to highlight first efgartigimod that demonstrated in myasthenia gravis really some very striking effects, as you can see on this cartoon. And you know that this has led to the labeling of this drug in myasthenia gravis. You can see really the significant effect that were observed with the drug. And I would like to end by highlighting that this drug is under investigation in systemic sclerosis. Here you have the criteria that are used. The patient can have a limited or diffuse subset. The key selection criteria is the MRSS, and of course the patient will be stratified according to the autoantibodies, and all of them must be positive for antinuclear antibodies. And the primary outcome measure will be skin. So to conclude, I think that we have seen today through the different presentations that B cells are important for contributing to the pathogenesis of systemic sclerosis through their antibody-dependent and independent functions. We have been progressing in the B cell targeting, and we become more and more precise in our intervention. We will get soon some new generation of anti-CD20 BAFF inhibitors and also some other cells like the plasma cells that will be targeted. There is some very stimulating data to support that some refractory condition may respond to CAR T cell therapy. Nevertheless, we have seen that some other opportunities may be different and provide different biological effects, from the full-scale depletion and reset to what has been proposed as a more diming strategy. This can be observed and obtained with the use of T-cell engagers, which is dialing down the B-cell activities and not completely turning off these activities. And also, you have seen another and innovative strategy that relates more directly to the autoantibodies by interfering with their recycling and interrupting their biological effects. So I think we are really at a very exciting time with several strategies that are becoming or will become available, and now we have to develop the clinical science to find which patient profile may benefit the best, the most of these different strategies. I thank you for your attention.
Thank you. Thank you, Yannick. Can we have also Chris on the screen? There was a very exhaustive, excellent summary of what's going on. There are a few questions coming up. One is slightly of a curveball, but it's very interesting. You're seeing in rheumatoid that the development of antibodies, autoantibodies, it's limiting the efficacy of biologic treatment, antibodies, anti-tocilizumab, anti-rituximab, and they are the source of secondary non-response. Now we're starting to use this biologic treatment in systemic sclerosis too. Does any of you have any experience on detecting these antibodies and associated with lack of response in scleroderma? I don't, so I say I will ask live.
Maybe I can start because we did that, for example, we did a study in all our CTD patients by using rituximab biosimilars. And we switched all our patients. And, you know, assessing the effect is not easy because usually the drug is similar and will provide the same benefit from a clinical point of view. But in order to be more precise about the effect, we measured the anti-drug antibodies carefully before and after the switch to biosimilars. And not only we found that the biosimilars were not exposing to more common anti-drug antibodies, but we found almost none in our patient with systemic sclerosis. So I don't feel that we may expect more in this part of the pharmacology related to biologics. But I don't know, Chris, if you have a different...
No, so we have some direct evidence that may support what you're saying as well. So it's because a few years ago, when it was first being used in rheumatoid arthritis, we undertook a trial of infliximab in systemic sclerosis, in early diffuse systemic sclerosis. It was a multi-center study led by our center and also by Ramburg Center in the Netherlands. And so what was very interesting is that the company at the time who was sponsoring the study were very keen that we didn't give those patients immunosuppression alongside their infliximab, and almost all of the patients developed an anti-drug antibody during follow-up. And so we were never really able to fully test whether this might be helpful for inflammatory changes in scleroderma, because we saw a transient benefit in one or two patients, but then that went, and at the same time the patients developed antibodies, and in fact most of them then got infusion reactions. So I think what that showed us is that your observation of a lack of antibodies may also reflect that most patients probably were on other immune suppressants when they were given their biologics. But so I think it is an issue, at least for infliximab. But as you know, infliximab is only a chimeric humanized antibody, and hopefully as we move, like with the B cell depleters, to fully humanized antibodies, it may be less of an issue.
Yeah. Very, very, very interesting. And then there were other questions. Of course, we can discuss a lot about what we are observing CAR T therapies, the first case series, seeing the drop of of autoantibodies and what does that mean? It could be a reverse biomarker now. We really don't know, but there is a question that is just opinion again. Is the B cell depletion not complete with the CAR T cells engagers versus the with T cell engagers of CAR T? So what do you think is the difference in what we're observing between engagers and CAR T as far as efficacy? Is that a matter of the depth of depletion or is something else?
I think, yeah, the potency is different for the tissue because this is where we want to go. We know that targeting the circulating cells is not enough. So we want to target the cells in the lymph nodes. We want to target the cells in the tissue. And the question is regarding efficacy and safety. Should we completely deplete the cells, or is it helpful to keep some cells available to produce the antibodies that are required for our defense regarding the infection and the virus in particular? I think this is the big question that we have in front of us. How far we should go, how much it is reversible, how long we have to wait. I have to say that I've been really striking by the data showed with the anti-BCMA T-cell engager, but at the same time, you saw the cost regarding the adverse events. But
Yeah.
where we want to go, this is what we will have to define with balance between strong, sustained effect versus some risk regarding the infection.
Of course, every coin has two faces. Well, we could stay here for a very long time because it's such an engaging conversation, but we are over time. And actually, what the last question received is a thank you note for a patient for all that we're doing and sharing the dream of scleroderma-free world. Indeed, that's what we wake up in the morning to do, and we'll hope to get there as soon as possible. And on this note, let me just thank the speakers again, Professor Kuwana, that now, of course, is in the depth of his night, Professor Allanore and Professor Denton, for sharing with us their knowledge and what they think of the field. And of course, I want to thank the technical team, Scleroderma Forum. It was not easy to merge this on a Zoom platform with Masa. It was recorded, and our sponsor Argenx for supporting this program and for taking the bet on reducing autoantibodies in scleroderma and see what is the effect on patients. So your feedback is so important for us. Here we are a group of people that are trying to spread knowledge on scleroderma and what's going on. And so please tell us what you think, tell us what we can do better, fill a short evaluation form that you will receive because you have registered. And this is the live stream version, but of course, there will be also on demand for the ones, for all the people. So if somebody has missed it and you want to suggest it, you can direct it to the website. On this note, thank you again. Thank again to the speakers and to our technical team, and stay tuned because we will coming back soon with another interesting topic. Bye, everybody.